Good morning, dear students. So today we are going to start with our third unit. In third unit, our first topic is epilepsy. So we are going to discuss what is epilepsy, what is the pathophysiology, signs and symptoms, and causes of epilepsy in this class. Okay. So coming to epilepsy, what do you mean by epilepsy? In generally, we call it as fits. In general layman language, we call it as fits. So what will happen in epilepsy? Epilepsy is defined by the occurrence of at least two unprovoked seizures. So seizures, that whatever the activity the patient do like jerking movements, that we call it as seizures. So what is epilepsy? It is occurrence of at least two unprovoked seizures with or without convulsions. So that we call it as epilepsy. Convulsions, that means violent involuntary contractions. Violent involuntary contractions are considered as convulsions. So when there are at least two unprovoked seizures with or without convulsions, that we call it as epilepsy, separated by at least 24 hours. So for to get initial evaluation of epilepsy, so the patient should get these episodes of seizures, at least two episodes of seizures with a time gap of 24 hours. Only at that time we consider it as epilepsy. Okay. So a seizure results from an excessive discharge of cortical neurons. So as we said that it's nothing but involuntary contractions. So in case of involuntary, for the formation of involuntary contractions, what does the things that are involved? There will be an excess discharge of cortical neurons and is characterized by changes in electrical activity as measured by EEG. So if you see this EEG, that is electroencephalogram, in that we can see the changes of excessive discharge of cortical neurons can be seen as a different changes in this EEG. Okay. So what is epilepsy? Epilepsy is nothing but it is defined by the occurrence of two unprovoked seizures with or without convulsions, that is nothing but violent involuntary contractions. At least two of these should be separated by 24 hours, that we call it as epilepsy. And also when this seizure occurs, so these seizures occurs when there is excessive discharge of cortical neurons, so which causes involuntary contractions. So when there is excessive discharge of cortical neurons, the seizure will be seen, and these changes can be seen in the EEG, electroencephalogram. So these changes in this abnormal discharge of cortical neurons can be seen in EEG. And coming to pathophysiology, so as I said that seizures will result as a result of any abnormalities or excessive discharge of cortical neurons, or from excessive excitation, or from disordered inhibition, small number of neurons fire abnormally. So when there is a discharge of disordered inhibition of neurons, initially small number of neurons fire abnormally. When the small number of neurons when they fire abnormally, this cause excessive excitation. So at that time we'll be getting these seizures. What was the normal membrane conductance? So generally there is a hemostasis will be there. Like excitation and inhibition should be done in an equilibrium, so that at that time only there will be proper functioning. So when excitation is more and inhibition is less, at that time we'll be having this seizure kind of activity. Normal membrane conductances, inhibitory synaptic currents then break down, and excitability spreads locally or more widely. If it is locally, we call it as focal seizure. If it is more widely, then we call it as generalized seizures. So as I said that when a small amount of neurons fire abnormally, what does it will do? It will change the membrane conductance, and also inhibitory synaptic currents. All of them will be damaged, like all of them will be broken down. So at that time what will happen? Whatever the excitation is there, that will spread locally or to a particular region or to the widely. If it is to the local, then we call it as focal seizure. If it is widely, we call it as generalized seizures. And then mechanisms that will contribute to the seizures include: first is alteration of ion channels in neuronal membranes. So when there is alteration of ion channels in neuronal membranes, it will cause influx or reflux abnormalities causing the excitation. And then biochemical modification of receptors. One is ion channels, alteration of ion channels in neuronal membranes. Second is biochemical modification of these receptors and modulation of second messaging systems and gene expression. Changes in extracellular ion concentrations, alterations in neurotransmitter uptake and metabolism in glial cells. Modification in the ratio and function of inhibitory circuits. That means if there is less number of inhibitory circuits, there will be more excitation. And local imbalance between main neurotransmitters like glutamate, GABA, and neuromodulators like acetylcholine, norepinephrine, and serotonin. So mainly, the main focus is mainly on the imbalance between these neurotransmitters and neuromodulators. So and then prolonged seizure. So these are the main 6-7 mechanisms which will which will cause the seizures. First is alteration of ion channels in neuronal membranes, biochemical modification of the receptors, modulation of second messaging systems and gene expression, changes in extracellular ion concentrations, alterations in neurotransmitter uptake and metabolism in glial cells, modification in the ratio and function of inhibitory circuits, and also local imbalances between neurotransmitters and neuromodulators. Mainly, whatever the neurotransmitters that are involved include glutamate and GABA, and neuromodulators includes acetylcholine, serotonin, and norepinephrine. And then prolonged seizures and continued exposure to glutamate can result in neuronal injury, functional deficit, and rewiring of neuronal circuitry. So prolonged seizures, that means if the seizures episode is for a longer duration, and if the and is continued exposure to glutamate is excitatory neurotransmitter. So in seizures, what will happen? There will be more excitation. So glutamate will be more, and GABA is an inhibitory neurotransmitter. So in case of this, there will be more amount of glutamate and there will be decrease in GABA. At that time only we'll be getting this epilepsy. So when there is more duration or prolonged exposure, so because of that, what will happen? Glutamate concentration will be more and exposure to glutamate also will be more, and can result in neuronal injury. So, and also this, whatever the neuron is, it will be coated with the a sheet. So when in case rewiring will be taken place in case of epilepsy. So that what will happen? Circuit, like normally short circuit and a wire rendu pine going on circuit of the same kind of thing happens in our brain. And then coming to classification of seizures. So it is mainly classified into 4 types. First is partial seizures, second generalized seizures, unclassified seizures, and status epilepticus. So in coming to partial seizures are nothing but seizures begin locally. If the seizures begin locally, that we call it as partial seizures. And again, it is classified into 2 different types. That is simple without impairment of consciousness, complex with impairment of consciousness. That means simple partial seizures, at that time there will not be loss of consciousness. When coming to complex partial seizures, patient along with this seizures like activity, he will be complaining of, like he will be in that condition there will be loss of consciousness. Again, in simple, it is of 3 types with motor symptoms, second with special sensory or somatosensory symptoms, and with psychic symptoms. So this, and coming to complex, partial complex, there will be loss of consciousness. Again, it is of 2 different types. Simple partial onset followed by impairment of consciousness with or without automatisms. So simple partial seizures, it's like simple partial seizures will be there along with impairment of consciousness. That means loss of consciousness, and impaired consciousness at onset with or without automatism. Like immediately there will be loss of consciousness. And third is secondarily generalized. Secondarily generalized is nothing but so first it will be like partial onset seizures, and immediately it is followed by, or it will be converted to generalized tonic-clonic seizures. So these are the different types of partial seizures. And then coming to generalized seizures, bilaterally symmetrical and without local onset. So like the symptoms will be like bilaterally and without any local onset won't be there. Like it will be spread a wider region. So that we call it as generalized seizures, and it includes 7 types. One is absence seizures, myoclonic seizures, clonic seizures, tonic seizures, tonic-clonic seizures, atonic seizures, and infantile spasms. So these are the different types of generalized seizures: absence seizures, myoclonic seizures, clonic seizures, tonic seizures, tonic-clonic seizures, and atonic seizures, and also infantile spasms. So infantile spasms that can be seen in like infants. And then coming to signs and symptoms. So you have to study it by yourself, like what is absence seizures, what is myoclonic seizures, what is clonic, and so these definitions you have to study by yourself. And also if you get any doubts, you can ask me for clarification. And then signs and symptoms. So symptoms mainly depends on seizures type, like type of, depending on the type of the seizures, like whether it is partial, complex, simple, or generalized. So depending on that seizure type, the symptoms will be there. Okay. Coming to partial seizures or focal seizures, so it begins in one hemisphere of the brain. So it starts in a particular location of the brain. Unless they become secondarily generalized, it results in an asymmetric seizure. So only when it will be spread to the other part of the brain, then only it will be converted to generalized. Or else the kind of seizures will be generalized, like it will be to the only one side of the brain. And partial seizures manifest as, so again as we have seen in classification, it has symptoms of like somatosensory symptoms or motor symptoms, like depending on the functions. So there will be these kind of things can be seen. And in this condition, the main symptom is patient may have memory loss or aberrations of behavior. That means during the period of this seizure, during that time, the patient may have memory loss, like what happened during that time they will not remember. And also aberrations of behavior, there will be fluctuations of their behavior. And a partial seizure that becomes generalized is termed as, so if a partial seizure is converted to generalized, then we call it a secondarily generalized seizure. Again, in complex partial seizures, what will happen? There will be impairment of consciousness and no memory of the event. Like they will not have the memory of what happened, and also there will be impairment of consciousness. So that we call it as partial complex seizure, complex partial seizures. And then coming to generalized seizures, in that absence seizures. So usually absence seizures occur in younger children or adolescents. So these will, so in this condition, there will be a sudden onset of seizures can be seen, and interruption of ongoing activities. That means if they are studying or sitting place and studying, suddenly because of this sudden acute onset of the seizures, there will be interruption of these ongoing activities and a blank state. Blank state means like this kind of expression will be there, like the patient will be looking at somewhere without any thought in mind, that we call it as blank stare. And possibly a brief upward rotation of the eyes. Upward rotation of eyes also can be seen, and there is only a very brief period of alteration in consciousness. So loss of consciousness that lasts only for few seconds. And absence seizures have characteristic 2 to 4 cycles per second spike and slow wave EEG pattern. So if you see the in EEG, it will be the changes that we see will be like this, like there will be spikes in this slow wave EEG can be seen. So once again, I'll repeat what is absence seizures. It will be seen especially in childhood or in adolescence. So in case of this, like there will be acute onset, and because of that acute onset of seizures, there will be interruption of these ongoing activities, and the patient will be complaining of blank stare, and also uprolling of eyes can be seen in case of absence seizures. And loss of consciousness will last only few seconds. And then coming to generalized tonic-clonic seizures, so these are more convulsive episodes. So, and these are associated with loss of consciousness. So, motor symptoms are bilateral. In generalized tonic-clonic seizures, all like both the hands are involved or both the legs are involved. So, it is bilateral. And generalized tonic-clonic seizures may be preceded by premonitory symptoms like an aura. Some like before you are experiencing these seizures, you are getting these seizures. Prior to that, you will be experiencing some kind of aura. That means some hollow sound is hearing, and some darkness, and some darkness, and like if at all if you go to the beach, near to the beach, you'll get some kind of hollow sound, so that you can experience before or the onset of this GTC seizures. And then these are generalized tonic-clonic seizures, and it is preceded by an aura, like a partial seizure that is secondarily generalized. And then coming to this, it begins with a short tonic contraction of muscles. That means there will be immediately there will be having contraction of muscles by a period of rigidity. So first they will be having these contractions and followed by rigidity and clonic movements. So this is how the patient will be exhibiting the symptoms of tonic-clonic seizures. So the patient may lose sphincter control. That means they will pass urine, they'll do involuntary defecation will be taking place. Bite the tongue, they'll bite the tongue and become cyanotic. So when they do this biting of this tongue, it will convert into bluish or blackish color because of this improper blood supply. So these kind of things, this is the most commonly you can clearly identify it as a seizure. So this episode is frequently followed by a deep sleep. After this, the patient will go into deep sleep. So okay, so in tonic-clonic seizures, what will happen? There will be sudden contraction of the muscle followed by rigidity and then clonic movements. Okay, because of these contractions the patient also loses sphincter control, so because of that there will be involuntary urination and defecation, and tongue bite will be seen, and also there will be cyanosis, and this will be followed by deep sleep. So that we can identify as tonic clonic seizures. And then myoclonic jerks, these are brief shock-like muscular contractions of the face, trunk, and extremities. So these are like shock-like suddenly. Sometimes when you sit in some extreme weathers, okay, like very cool weather, sometimes unknowingly you'll get some kind of jerks. That we call it as myoclonic jerks. Okay, so these kind of jerks can be seen on face, trunk, and also extremities. And this may be isolated events or rapidly repetitive. So sometimes they are like single episode can be seen, or sometimes repetitive myoclonic jerks also can be seen. In atonic seizures, there is sudden loss of muscle tone that may be described as a head drop, drooping of limb, and slumping off to the ground. So atonic seizures means suddenly the body will lose its tonicity. Suddenly the patient will fall, like droop of his head. Sometimes if the hand is like this, it will lose its tonicity, and suddenly there will be falling of these limbs and also slumping to the ground. All of a sudden the patient will fall to the ground. So that we call it as atonic seizures. Now then coming to diagnosis. So first we have to ask the patient and family why, because the patient will lose consciousness, so he cannot explain what happened to him clearly. So whoever the person who is residing with this patient at that time, we have to ask that attender or a family, like to characterize the thing, to describe the thing what happened at that duration of time. So it includes like seizure frequency, like frequency, that means like how many times the same kind of repetitive like seizures like activity has experienced by the patient, and duration of this seizure like activity, and precipitating factors like whether the patient has taken any alcohol, or whether he is under any stress, or whether he had any head injuries, or that kind of precipitating factors also we have to ask, and time of occurrence, like at what time it has been. And also we should ask the patient whether there is any presence of an aura is there, and ictal activity and post-ictal activity. So ictal activity and post-ictal activity is nothing but the patient is complaining of any other like, wait a second. So that again I'll tell you what is that post-ictal activity. So ictal activity is nothing but there will be like stroke or headache kind of thing kind of thing that we call it as ictal activity. And also in EEG there will be this kind of changes can be recorded, that we call it as ictal activity and post-ictal activity. That means the EEG which is taken during and after this episode, like what is it showing, that we have to check. And physical and neurological examination, like physical examination, whether if due to any tongue bite, that we have to check whether there is any tongue bite or not. And neurological examination, like we have to ask the patient about his memory and consciousness and whatever he reminded, and how, like whether he is having an experience of like headache. Also all this neurological examination we have to check, and laboratory examination may identify an etiology. So if we identify all these, we can get to a conclusion that what was the cause for this kind of seizures. And laboratory tests include, like immediately after generalized tonic-clonic seizures, if we check these prolactin levels, they may be slightly elevated. So if we check the serum prolactin levels immediately, like within few hours after this episode, then only this prolactin levels elevation can be seen, like 10 to 20 minutes of a tonic-clonic seizure. So if you see that prolactin levels, if it was found to be elevated, then we can differentiate it from the syncopal attack. Syncopal attack is nothing but it also looks similar to these seizures, but it is not considered as seizures. And then CBP, CUE, and special blood chemistries also can be done. Why? Because like whether there is any infectious conditions or whether there is any severe anemia, and CUE and special blood chemistries like electrolytes also we have to check. Why? Because electrolyte abnormalities also causes seizures like activity. So in order so and also RBS, that is random blood sugar, also has to be done. So all this will help in ruling out whether it is not, it may be to rule out any hypoglycemia is there, altered serum electrolyte concentrations, like if there is more amount of potassium also it causes seizures like activity, and infections. If there is sepsis, there all at that time also they will be having this myoclonic jerks also can be seen, which do not these are the things that which should not represent epilepsy. In order to rule out all these things, we have to check this biochemistry test. And a lumbar puncture may be indicated if there is fever. If the patient is having fever, then we have to do this lumbar puncture. Lumbar region, in that between these two spaces of lumbar bones, they will be introducing one needle and will collect that CSF, that is cerebrospinal fluid, will be collected in order to rule out whether there is any infections which cause like encephalopathy. So in order to rule out that conditions, we can go for lumbar puncture if the patient is having fever. And then other diagnostic tests include EEG. It's very much like pretty much it will mostly depend on this EEG in order to identify these seizures. But epileptiform activity is found in about 50% of patients with epilepsy. So EEG is most commonly used, and also MRI is also useful in order to rule out any changes in the brain, so especially in the temporal lobes. So for that we'll go for magnetic resonance imaging, that is nothing but MRI. And then CT scan, that is computed tomography. It is not helpful only in order only when there is any bleeding in the brain, or any tumor in the brain. At that times only we can, this CT scan will be helpful. If these two kind of reasons are not there, then this is not helpful to rule out seizures. So going for MRI and EEG is the better options to go for diagnostic tests. And laboratory tests include CBP, serum prolactin levels serum prolactin levels will be elevated in case of tonic-clonic seizures. So that we have to check that also within 10 to 20 minutes after this seizures like activity, then only you can see these changes in this prolactin levels. CBP, CUE, and blood chemistries like blood sugar levels, all these, and serum electrolytes, all these are also done in order to rule out any hypoglycemia or any electrolyte imbalance, which may also cause seizures like activity. And if there is high grade fever, then we have to go for lumbar puncture, and we have to collect this CSF, that is cerebrospinal fluid, and we have to check whether there is any infection which is entering into this brain. So these are the different tests that we have to perform in order to rule out epilepsy. So this is all about the definition, pathophysiology, signs and symptoms, and classification and laboratory manifestations of this epilepsy. So in the next class, we'll be discussing the treatment of epilepsy. So with this, we'll be ending up this class. Thank you all.